One. Hello and welcome to Confronting the Complex. This is Dr. Jamie Kunkle, and I'm joined once again with Janell Payne, Dr. Janell Payne. Today, we're going to talk about some really cool stuff. But first, how are you doing today, Janell?
I'm good. A little punchy. It's the end of the day. Big
Yeah,
long
I feel that. End of the day on a Monday.
I
Living
know,
in
right?
California. So there's
And
the
it,
Golden Gate Bridge behind me. That's right. I'm actually like probably about 10 minutes from here, honestly, from there. So probably looks like that too. It's been a nice day today, like 74 degrees. It's crazy for the Bay. Um, so
it's
what are we
about
gonna talk?
it's about that here and it's beautiful.
Oh yeah, in Oregon too. Gosh, I
Yes.
know I'm missing all the, prime growing
I
time.
know I should show you what it looks like out my window. It's gorgeous, but I
That
won't. It's all right.
yeah.
I should be
Well,
out there in it.
I'm in
But
a boring hotel room, so what can I say?
we're dedicated to the podcast.
Dedicated to the podcast. So today
Right.
we're going to talk about testing for infections. We'll have another segment probably on testing for toxins, probably mold mycotoxins specifically, since that's a big talk of the town. As everybody who has any familiarity with complex chronic illnesses knows, um, any complex chronic anything, there's a lot to discuss in terms of testing. Absolutisms, as if there was such a thing, or really don't exist.
They don't exist.
They don't exist. Yeah. So we're
Yeah.
going to go through some of our favorite testing, some of the stuff that we've found to be very helpful clinically speaking, and discern a little bit, when you use what, why would you use this test versus that test possibly, but we won't go into too much crazy like nerdy detail. Although I might, I don't know. Janelle will keep me in check, but
I know. We're trying to keep this like clinical level, like to where like kind of what we'd share with our patients.
yes,
But first, Jamie, I
yes,
want to ask you, like,
yes.
what about when patients say, I need you to rule out Lyme? I need you to rule out Bartonella. Tell me what happens when they say, rule it out.
Roll it out. Oh my gosh. Well, still to this day, I kind of try to tell them that like, well, first of all, rarely those things exist alone. So sometimes it's like it could be Bartonella plus something else, and sometimes maybe it's Bartonella and mold even. Maybe it's not just
Right.
an infection problem. So I gotta try to tell them like I'm gonna evaluate what I can in the infection realm, the infection landscape, but I have to also understand what's going on in the terrain, your immune system, and everything else in between. But usually I'll say the testing's not perfect, depending on how when the exposure was or presumed to be, because some people remember
Right.
having a tick bite, let's just say, if you're referring to tick-borne infections, although there's other vectors for these infections. It's a complex question with a long-winded answer that I usually give them, but I will say I will choose the best testing that I see helpful and combine that with my clinical understanding of your situation, which is your full history, your complaints, the patterns of presentation, and the physical symptoms or the physical elements that you're presenting with when I examine you and everything like that in between.
And can you ever really rule it out?
No.
I guess that's my one, like at the end of like all that, like, right? We try our best, but can you ever rule it out?
Not completely, unfortunately. One thing we got to, I'm sure most people know, but these creatures are really good at hiding. They're really good at either camouflaging themselves in some way or hiding in spaces or purposefully uh, dampening the immune system response. They're pretty smart, and
Yeah.
they're really good at doing that. Like Lyme Borrelia doesn't really hang out in the blood all that much. It might travel through there sometimes, but it's like mostly maybe in tissue that doesn't have a lot of blood flow. So it might
Right.
hang out there for a while. So it's hard to really say. And then, the other side of the coin is like, well, that just means everybody probably has Lyme or everybody has Bartonella. I was like, but yeah, there's
I
a little
mean,
maybe.
I mean, certainly we are biased in our view of that. But I do tell my patients, like, look, if I were to test the general population, a lot of people in the general population are probably positive with
True.
a total functioning immune system that they don't have compounding factors that make them more susceptible and be symptomatic, right? Being positive is not the problem.
Exactly.
Symptomatic is.
Yeah, it's how the system is responding to it or not responding to it. Sometimes it's over
Right.
responding to it, more hyperimmune, sometimes it's under responding to it. Or sometimes that thing is just, like I said, confusing or damping the immune system, and then the immune system is struggling with other things around it. So it could be struggling with run-of-the-mill infections, and it may not be that that infection is the problem. So yeah, but if you do test the general population, go out there and test yourself, and scare yourself a little bit, you might be positive too. It's quite possible. It's not unheard of. So,
Yeah.
uh-oh, my internet
I
connection
missed
is
some of that. I
unstable.
think I don't remember if my internet spazzed or your internet spazzed. One of them
Oh,
did.
it's okay. That's the real time that you guys
Um,
get today, because we're not at our, I'm not at my fancy
Real time.
home studio. So this is what you get is internet
I know
happening.
my home internet is way more reliable. This internet at the office has too many people on it, too much business. It's
Yeah, it's
not as
wireless.
reliable.
I'm always wired at home. That makes a big difference.
Yeah.
So I was
It
saying,
does.
what was I saying? I was saying,
I don't know, you trailed off.
oh yeah, I suppose so. I was talking about it's the response or lack of response to the infection that's really most important, not necessarily its presence or absence. Because I agree with Janelle, if you tested the general population, if you tested yourself tomorrow, you may actually harbor some of these creatures too. And it's a classic story I've seen with many of my patients that they were completely fine regulating all of this stuff until some kind of turmoil happened in their system. It could be COVID in some cases, it could be a trauma response, like a physical trauma, or even a very intensive emotional response, maybe a grief reaction, even it could be a
A
surgery.
move, a divorce,
Yeah, divorce,
a
classic
breakup,
stories. Yeah.
yeah,
Times
yeah,
of hormone shifting in life, either puberty or menopause,
right,
perimenopause, andropause. The guys aren't, exempt from that either.
yeah.
So yeah, so it's interesting.
So I'm curious, like, okay, if you can't rule it out and if you're testing, like what do you tend to do for brand new patients that come in and they say, yeah, so I've been tested for Lyme, it was negative, and what else could there be? What do
Right.
you say to
Like, well, I may need to take another look at that for certain, because Lyme testing is notoriously a little iffy in terms of any absolutes, as mentioned already. And I need to look at your symptom arrangement and see if it fits a pattern that looks like it could be in that realm. And then there's nuanced testing or different ways to look at it, which of course we'll be discussing here in a moment, that may allow us to look at it maybe from a different lens, or from a different just a different viewpoint perhaps. And we'll go into what that means. And what's now may not be what was then. So
right?
that's a big thing to understand. Like, you could have had Lyme in the past, but that may not be your problem now. Maybe it was a catalyst for leading to where your problem is now, but what is now is not always then. So it could go both ways. You may not have tested positive before, but you might now, because of a multitude of factors.
And do you tend to see, like, amongst your patient population, like, what are the top infections that you see repeatedly showing up on tests? And it may be because that's what you're testing for. In my case, it's probably what I'm testing for because I do what I call high yield testing to try to save people money.
Yeah.
And we'll talk about that a little bit briefly. But, what do you think about, like, what are your top uh, pathogens that you see coming in?
Yeah, sure. I mean, I think given I'm seeing people that presumably have had complex, tick-borne Lyme syndromes. I mean, the three Bs are my top three. I mean, Borrelia, Babesia, Bartonella are the three that I often see the most. And it doesn't mean that they'll all show up together. Sometimes they do, which is kind of a, probably a significant situation. But that's from the tick-borne sort of realm, or the vector-borne realm. Those are the three that I see the most. And occasionally you'll see other co-infections. But then opportunistic infections, speaking, of course, all the viral elements, those are, well, we could talk a little bit about those. Maybe we have a separate segment on some of the opportunistic things like
Right,
Epstein-Barr
I agree.
virus and all
Yeah,
that kind of thing, and mycoplasma pneumoniae and chlamydia pneumoniae, not the sexually transmitted chlamydia, different chlamydia. But
right. That's what
uh,
I always say too.
I know I gotta tell
Nobody
people
get
that it
alarmed.
gets
Nobody get alarmed.
scary. It's like, no,
Yeah,
you didn't get chlamydia. I mean, well, you got chlamydia, but not that one. Yes.
yeah,
Not gosh.
I'll take
Yeah.
that.
So yeah. So it's kind of one of those things where these infections do show up a lot, because I think that person presumably is probably sick and has some dysregulation and that kind of thing, and they are common players in some of those manifestations that we see. That doesn't mean that they're the end of the story, as I just said, but they're an element that you do have to consider as you're dotting your I's and crossing your T's in determining what is create, what is potentiating this struggle, this dysregulation that person's
Right.
presenting with. So yeah, those
And
are,
I see the same thing in my practice.
yeah.
Three B's, the Bartonella, Borrelia, Babesia, for
Hmm.
sure.
Yeah.
Um, and I used to think Borrelia being Lyme. A lot of people don't know that Borrelia burgdorferi is Lyme, but
Right.
a lot. I used to think that that was the predominant pathogen, and I no longer think that's the predominant pathogen. I would say Bartonella and Babesia are definitely more predominant than that. And we have a lot of tick-borne relapsing fever in our area as well, and ehrlichiosis. So
Yeah.
I definitely see that. But the three high yield, same as you.
Yeah, totally. And I mean, I think that that brings up an interesting point too. We do have to consider what, environment we're in or like what location we're in and sort of what's common around us. And as practitioners, that's something that's very important. So when we're taking that history, we're also asking people, where have you lived? Where have you been? And I think that's going to be important as we sort of segue into the testing too, because a lot of this testing was designed for East Coast Lyme, Connecticut Lyme,
Right.
Burley Burgdorferi and its friends. And much of that testing has not exactly been updated in a meaningful way and also not
And
updated to West Coast, elements.
we have tick-borne disease on the West Coast in high numbers. Like when they say that there's no Lyme in Oregon, there's no Lyme in California, that's just malarkey.
Yeah,
It's just
it's
not what
wishful
we see
thinking.
clinically. And
It's
these are patients that haven't traveled.
Yeah, totally.
They haven't
Yeah, no, you
traveled.
can find
Anyway,
them. They're
so
patients who've been born and raised, that never left, sometimes never left the county in some cases, you'll find some of those
right,
patients sometimes.
right.
And like, well, where could it come from? Well, it's probably from that state. And there's plenty of documentation on that. There are ticks around. I mean, I think just like California and various other places on the West Coast who in the past have been considered not a problem with Lyme, there are pockets in each of those states that are higher, in terms of the presence of the ticks, of course, and then the presence of the infected ticks, and then
Right.
the transmittant, the rates of transmission and everything. So you will have pockets that are as bad as New England, for example. You might find those pockets in certain areas that you don't expect. So understanding if you are in that area, in one of those
Right.
endemic areas, is really important as a practitioner as well. So the more we deny all these things, like it's not very productive for trying to, discern this from a public health, perspective too. Um,
So if I'm a patient and I come to you and if I say, look, I have like not a lot of money to spend, not a lot of discretionary money to spend on testing. What
mhm.
are you going to recommend? Then alternative scenario is I have about $1,000 of discretionary money and what tests are you going to recommend? And then other scenario, some of our patients are like this. I have unlimited pools that I want to spend and really figure this out. What testing are you going to recommend? So I
Yeah,
know that we try to strategize for our patients. Sometimes I
totally.
try to strategize too much and I try to limit their expenditures too much. And really, sometimes patients just want to like have all the information possible.
Yeah, and I've run into all three scenarios. And so let's just say patient number one has Medicaid or something, doesn't have a lot of out-of-pocket money. I try my best to run the testing, understanding the limitations of the conventional testing, and I'll preference, of course, the classic Lyme Western blot with the different bands, the IgGs and the IgMs, for example, which is probably the most valuable of them. There are some newer Babesia tests, like there's a Babesia Duncani test on one of the LabCorp it's been more helpful lately. So occasionally you'll catch something on there. So for that patient number one, I'll use the conventional testing and I'll look at the immunology around it. I'll see if it sort of makes sense. I'll maybe use the MSIDS questionnaire from Horowitz or something, or like I'll use other, clinicals to supplement the diagnosis in that case. And that's kind of how I had to operate in Vermont to some degree. Of course, in Vermont, that was an area that was endemic that I think the testing was better for. Like if a person got a tick bite that day, you could test them that day, which would be way too early, but if you tested them that day, they would test positive because they were already positive. So like
Right.
in some ways, I mean, you had to just like rely on clinicals there. Like you got to assume everybody, who's been exposed that many times is going to be positive. But so that's patient number one. Patient number two, that's more like $1,000 budget. I might be like, okay, well, let's look at the three Bs at least, Borrelia, Bartonella, Babesia, and I might do, IgG immunoblots or something like that because I can maybe get some better speciation and I
Right.
can do a classic.
They're about $255 each.
Yeah,
Right.
yeah, totally. So you get about
750.
into that realm. Yeah. And so it's totally possible. And then the person who's kind of like throw it at me, I mean, it depends. I these days I may for a while, like some of those folks, I would do two tiers of testing. I would do maybe some of the classic antibody testing that I sort of mentioned, and then maybe I would throw one of the newer tests at it, either the lymphocyte test, which we can talk about in a minute. They look at the immune system from a different lens, not just antibodies, or I might, throw some of the fancier like T labs type test, it's more RNA or more direct testing, and then compare those together and see if they sort of make sense. Because you want to see if the immune system is or is not responding to some degree, but it's also nice to get an idea if there's evidence that it exists at all within the system at the same time. And then you can get some sort of gauge on some of the immunology, like as far as response, lack of response, chronicity possibly, because sometimes the antibodies go down the longer one has the infection too. So
So are you suggesting with the three different tiers of testing that you would recommend for patients? And obviously we have to work within patients' budgets, but would you say that the testing gets better and better as it gets more expensive? Are you
not
at the wrong
necessarily.
range? What are you saying there?
Well, I'm saying that it depends on what you're asking, of course, but like I think that you can get more nuance to understanding sort of what's happening in the system if you do sort of different varieties of testing. And whether you do it all at once or you kind of, do it over time, I think it can help sometimes for the really complex cases. And I'm talking about the ones that it's sort of an uncertainty at this level of the game whether those things are still a problem. Maybe they've treated already, because oftentimes when the time they're seeing me in our clinic, they've seen like three or four other doctors or sometimes 20 doctors or something, and like, did they treat already? Was there, other things that that have happened in their body that would sort of suggest that there needs to be a more robust reevaluation because they're one of those people that doesn't test out very well. In that case, I might look at it from some different lenses, and I might run all the like more extensive co-infection testing and opportunistic infections. Like I found a lot of brucella lately. It's like most people don't like, screen that in the first run. So it really depends on where the person's stepping into the journey. If it's like a newer illness, there's not always a need to go that deep and far because you're often treating what you see and you don't see with the treatment, and they're responding to the treatment. They're responding to the antimicrobials in those cases. But the folks that are really chronic have had these things for a long time and have layers upon layers upon layers upon layers. Trying to be as precise as I can in determining what, who, when, where, and why sometimes serves a purpose, but it is
Sure.
really circumstantial.
So a scenario that I always really appreciate coming into my office is a patient that's tested negative previously, right, to tick-borne diseases. Antibody test, usually an antibody test, they test negative too. Sometimes the RNA tests, right? And then they come in, they've been treated presumptively because the practitioner still felt like they were positive. And I so appreciate that, right? They come in, they've had some positive response, or I shouldn't say a positive response. Sometimes I call it a confirmatory response to treatment because it's not always a positive experience for the patient, right? And so a confirmatory response to treatment. And then I get the privilege of retesting them and they're positive, right?
Mhm.
Because we all know that the patient will often come in first round, right? They'll be negative. You treat them, and now all of a sudden their immune system is seeing that pathogen, right? We kind of smoke it out, for lack of a better word. And now they're seeing the pathogen.
Yeah.
Yeah.
Yeah, that's called a provocation, which you can do provocations in many different ways. Just the same way we will provoke toxins, which we'll talk about later. You can provoke infection testing, and some people do that. That's another way to kind of deal with scenario one patient sometimes is like scenario one patient doesn't have a lot of money and resources, but you might be able to give them, if you're expecting it clinically, you might be able to give them a short course of some kind of treatment that would provoke that response. And then if you wait like 3 or 4 weeks or whatever and test them again, you might see a higher amplitude response there. So you can wake the immune system back up, which is as appropriate with most infections. IgGs and whatever go down over time and they kind of start to diminish. But as soon as the immune system catches wind of that thing again, it's like, shooting back up. So
I had a patient once that when we tested her, she was negative, right? And we'll talk about the CDC positive, the IGeneX positive. Some of the different labs have different criteria. So she wasn't positive at all, right? She had a negative Western blot, then or immunoblot. No, it was a Western blot at the time. It was before there were immunoblots. This is several years ago. And we treated her about 6 months in. I want to retest, right? So we retest, we run it again. She's positive. I said, you're CDC positive for 2 patients now. Like literally every band lit up, which was shocking to me. So definitely and I don't know, I can't even tell you where that sweet spot is, somewhere between 1 month and 2 years.
Yeah.
You know, to get that response. But I've tested patients up to a year later, and they finally tested positive.
Yeah, and I think it's considered it can be considered positive. There's like there are patients that are kind of more hyperimmune that just like blast out immune signals all day long. And then
Yes,
there are these patients who kind of on that more sluggish sort of low, sort of end. And some of those patients do end up, being a little bit more on like the immune deficiency type spectrum. If you want to measure IgGs and stuff, you might measure them low in immunoglobulins or whatever. But anyway, long story short, I mean, sometimes as you're treating those people, the people on the lower end, their immune system does start to wake up and you start to get responses out of them. And like that's actually kind of a cool thing. So it's like, yay, I'm positive, as if that's such a phrase.
I know, I know.
But
Yeah.
it's like to
And
do is a
and
problem.
let's ask this also, like, do you test IgM and IgG?
I mean, it depends. I will sometimes because I see a lot of persistent IgMs with people, even when they're
Yes,
chronic, and like, it shouldn't be that way, but sometimes that's all I have to go off of is
I
IgMs.
agree.
I don't see any IgGs. It's like we some of us will treat until we see conversion of IgM to IgG, the seroconversion they say, that leads to more long-term robust immunity because IgMs are not very good for neutralizing. They're not really good for neutralizing anything.
Right.
But the IgGs are way better. So if you see somebody that's just stuck in IgM mode, it's more of a
Some
reason.
critics of antibody testing will say that when you get a positive IgM, that can be just an aberrant immune response. It doesn't have to be a targeted immune response.
Yeah. Well,
Has to occur.
maybe.
However, I'm with you though. Like in the interest of saving patients money, I usually go just stick with IgG, right?
Yeah.
Even though I know, and I try to tell patients this, but this is why we're having a podcast so that patients can refer to this podcast for the things that we might miss being able to say in person, right? But
Yeah.
the IgM, I'm by not testing IgM, I might be missing some cases. Frankly, I might just be missing that, especially for those IgM persistent cases, and there's plenty of them.
Yes.
Plenty. I mean, no shortage. Then the what else was I gonna say? Oh, so I don't test the IgG, but on the other hand, I just it's always this balance. Like, do we want to spend another $250 on that? So
Yeah, totally. And that's
sometimes
where you
yes,
put your people into the little tiers, and then there was a time when I would just run like a IgG, IgM, Borrelia sort
right,
of, setup, or I would hone in on one of the infections or something, or, whatever, run a Galaxy or something on Bartonella. I mean, you can mix and mash or sort of like stagger it kind of depending on where you're looking. But yeah, I think yeah, IgMs are clunky and weird, but we're seeing a lot more of them with a lot of different infections like
so
persisting. So I think they are probably considered to be, not the most functional way that the immune system could be responding to these things. But like I was trying to say, I think I try to take data when I can take it as far as understanding like how that person is able to respond or not respond. And then and I'll always treat IgMs. And in some ways, like you could argue, oh, maybe it's a false positive or whatever, but it's like IgMs are, in some ways more justified from a conventional angle. It's like, oh, it's IgM, that means it's acute. That means you should treat it.
but at the same time, I agree with you. The patients that have positive IgMs usually respond really well to treatment.
Yeah.
So I do see that. Like,
Yeah.
and they would respond well to treatment if it was a false positive, right?
That's it. That's really comes down to at the end of the day is that they wouldn't really
Right.
be responding to treatment unless you're treating something else. It's not that. But like
Right.
I
Don't
said,
get
every time you're treating, you're always treating the seen and the unseen. So there's always a possibility that something else is happening. But if you're
right.
seeing it more often than not clinically that they respond to IgM, when you treat IgM positive folks, then it's kind of hard to deny. You could
Okay,
speculate.
so we're talking over some people's heads, like, right? Like
Oh yeah.
we're talking about IgM and an IgG. Tell me, tell me what gives there. What are we
Sure.
talking about?
Yeah, and let's just like overview a little bit because, okay, so when you're testing these infections and any infections, conventionally speaking, most people are measuring antibodies. So antibodies are, it's a part of your adaptive immune system. It's part of how your immune system creates long-term immunity. Because we've probably heard about this too with like vaccines or, getting early childhood illnesses, like let's just say old school chicken pox. People don't get that anymore. You get an IgM response acutely to an infection. That's like initial response over the first, week or two. And then that turns into an IgG later, or what it called a seroconversion into IgG later. So most testing out there is looking at a very simplistic way of looking at that immunology: IgM acute, IgG chronic, or another interpretation is IgG positive means past exposure, which is incredibly simplistic because if the IgG is extremely high, it suggests there's been probably recent activity in it. As I mentioned recently, the IgG kind of goes down. So you have this sort of curve where acute IgM goes up. As IgM comes down, IgG goes up. And then IgG starts to come down. And then, oh, but there's another exposure. Okay, it comes back up.
Right.
But,
Yes, and I see this a lot, and it's confusing because I tell patients all the time, IgG is past or persistent. Think past or persistent, and it depends on what doctor you talk to. A lot of doctors out there will say that's a past infection. That's all it is.
right.
We know that can be a persistent infection. And somewhere the arbitrary gods in the laboratory world will say 3 times the elevation. Oh no, 4 times the elevation.
Four
Some
times.
labs will go 5 times the elevation
Right.
of the lowest threshold. If we see that in an IgG, then that means it's positive. It's so
Yeah.
arbitrary, right? Like somebody just said, we're going to guess that this much. When really, we see this a lot with mycoplasma. I don't know about you. I see mycoplasma all the time, right?
Yeah.
Um, yeah, especially this IgG, IgM. IgM will pop up. And then I think, okay, it's reactivated, right? Oh, IgG is really high. Okay, that's reactivated,
Right.
At the end of the day, does the patient respond to treatment?
That's it.
Period. Period.
That's
Yes.
it. So
Yes.
yeah, I mean, so these IgG, IgMs are like the sort of cornerstone of most of the testing for infections, and it's everything from the ELISA to the Western blots to the immunoblots to the let's see, what else did I miss? Yeah,
I'm
I'm
I'm so
sorry.
glad you mentioned ELISA. Do you
Yeah,
like the ELISA? Do you use the ELISA?
not really too much, but
Never ever. No. But
no.
but the conventional labs make you now run the ELISA to run the Western blot.
Yeah.
Like Quest and LabCorp, uh, I have a hard time getting them to run a Western blot now without running the ELISA. And if you are ELISA negative, it will not reflex to the Western blot. That is a huge flaw.
Yeah,
Huge
because
flaw in
if
conventional
the
testing.
Western blot was positive, it sort of trumps the ELISA anyway. But that's the sort
Yeah.
of classic two-tier testing that is sort of still ingrained in the Lyme tick-borne world, in
Yes.
terms of needs, and that's a problem because that's not
That's the problem. And that testing was set up for surveillance, and that testing was initially to weed out vaccine positives,
right.
right? So we circumvented that, but in the end, what we've done is we've created a lot of false negatives, people not finding the right answer for their
Totally.
so,
Even the Western blot as it stands right now with the bans on a LabCorp request, still has false positives and false negatives, honestly. Like the
right.
antigens that they use may cross-react with other things. You might get cross-reactions with other bacteria, you may get cross-reactions with certain viruses and stuff. So
Right.
it's not great. It's about maybe a 50% sensitivity. It's like I said, if the person doesn't have any resources, it might be okay as a screener because occasionally you might come up with something with it, but generally it's an old testing platform that needs to be updated. And so, IGeneX developed the immunoblot, which is sort of a different form of the Western blot, but the sensitivity and specificity goes supposedly, according to their data, from 50% to 92% or so. So
Right.
it goes from a flip of a coin to a little more of, some level of
Yeah.
certainty if you're going to use antibody testing. And of course, as you mentioned, a lot of these different testing platforms have alternative criteria for positive. Uh, because the CDC criteria also needs to be updated, is fairly narrow in terms of what's positive and what's considered positive or accepted positive or not. So,
Right.
and it's just kind of weird because they'll include some antigens that do have a potential to cross-react and be non-specific, but they'll disclude other ones. Like the 41 band IgM can be considered helpful, but then that can just be like some flagellate, creature. But if it's an IgM, it's okay. It's not okay if it's an IgG. And then the 93, it
I know. We could
goes
really,
on
I
and
totally
on.
agree. I
Yeah.
know, right? And okay, so what's your favorite lab? What's your go-to lab?
Well, it depends on the day because
I
the
know it depends,
other,
but like just like if you had to go, okay, if you were testing you and you
yeah.
had whatever resources you could, like what would you do?
I mean, I'd probably still run IGNX first for most people. I
Same.
mean, I'm really intrigued by some of the newer testing platforms like T Labs and stuff, but I mean, I might do that, but I think the thing about the IGNX is it gets closer to precision and speciation. I think that that's kind of an interesting thing of like if you want to try to get a clearer view of like who and what it is. I don't know. It's not always useful data. It's like if it's Bartonella, it's Bartonella maybe in some cases, but Bartonella Henze may be slightly different than Quintana or maybe slightly different than whatever. So it's just one of these things. I think you get more bang for your buck on those testing in terms of screening. And then if you're not getting your answers from there, maybe you move on or go different things. I went into the lymphocyte testing for a while. So like I'll explain really quick, like the other side of your immune system, it's actually the first part of your immune system, what's called your innate immune system, like sort of that first response to things, like the lymphocytes are in there, mast cells are in there, all kinds of important immune cells, and those things end up signaling your B cells to create the antibodies. So that part of your immune system can also be measured, and what that's supposed to tell you or tell us is that what are you currently at this moment in time reacting to? So even if you got like a tick bite and you measured lymphocytes within a day or two, they could theoretically be reactive because they're the first line of defense to the outside world. They're there to, moderate those responses to communicate to the rest of the immune system and try to get things rolling in the right direction. And so that testing is cool. This is like the ELE spot technology, for example. The IGeneX has the IGeneX spot, and then there's the Armin labs and Infecto labs, and there's several
Right.
different labs that do these. I'll tell you this, I mean, I don't know what your experience is with them, but I'd say they work when they work, or they're helpful when they're helpful, and they're not helpful when they're not helpful. So, like, in other words, if somebody's positive and you get this nice sort of array of like what their system is currently reactive to, and then you treat them, and then they clinically improve, and you retest it, and then all that stuff comes down, and then you keep retesting it, and it stays down, it looks good. There's a conversion in the infecto from one that looks like an acute to a memory response, which is kind of more of an immunized state, so to speak. It works great. But I mean, so I went through a kick of doing a whole bunch of those. And I mean, I'm not saying I don't still do them sometimes. It's really circumstantial. Like I really love doing those tests for viruses, which we'll talk about sometime, and some long COVID stuff. But yeah, my initial go-to is definitely the IGeneX. What's your opinion?
Yeah, I tend to go with IGeneX. Like if I have my druthers, right? Like I would say my standard thing is Bartonella, Babesia, and Borrelia, all immunoblots through IGeneX. Immunoblot IgG. And I just run those three. Now, granted, if I get the sense that the patient wants more in-depth testing, I'll do an expanded panel. I actually do find that running fish testing is superior, right? Like maybe not superior, but it gives us a better indication of what is an active infection versus something that could be construed as a past infection, right?
Yeah.
Through
And
through
that kind
some.
of brings us to
So
our other type of testing really quick, which is our what they call a direct test. It doesn't involve the immune system whatsoever, and that would be your DNA, RNA testing. So fish is a RNA test, so is the T lab,
yeah,
which is a form of fish technology, is my understanding. And then
yeah,
you've got PCRs and other lovely things, culture enhanced PCRs, cultures in general, which aren't that
yeah.
cool usually, but
And then there's even some culture like you mentioned the cultures that is really interesting. There was a lab. Who was that lab a long time ago? I believe Dr. Biroscano was affiliated with them.
oh,
Oh gosh, it's probably been over a decade ago, and they were culturing Bartonella.
yeah.
And I remember Dr. Burroscano at a conference, him saying, "Okay, so what we have found is that Bartonella is really, really picky. It doesn't like clear glass; it likes frosted glass. It doesn't like 36 degrees; it likes 38 degrees, and it doesn't like what is bovine serum; it likes rabbit serum, right? Like
Yeah.
all these things were like so
That
specific.
that was probably Galaxy because they made a
Galaxy.
specialized brew that was
Oh,
proprietary that was like the Bartonella food. That was one of the
yes, but
original
but I
culture
think that
enhancements.
he was talking about it was a different lab at the
Oh,
time.
it might have
It
been.
wasn't Galaxy, but I'm glad you mentioned Galaxy. I actually really like Galaxy Labs.
Yeah.
There's no reason not to use Galaxy Labs.
Yeah.
I only got away from you froze. Sorry.
Oh, that might have
But
been me.
I only got away from using Galaxy Labs because the like hygienics technology became such that I could do all the lab testing there. But I used to split my lab testing, go some to Galaxy and some to hygienics.
Right.
And because it's hard to do that, right? That's two test kits, it's two test tubes. And when you're talking about a pediatric patient that you're going to get three test tubes, that one extra test tube makes a big difference. And so there's no reason not to use Galaxy Labs. I just happen to think that Igenix does better for Lyme, and I think that Galaxy does better for Bartonella.
Yeah.
And like Igenix kind of up their game, and maybe Galaxy is up their game in Lyme now. So what do you have to say about Galaxy Labs?
Yeah, I use Galaxy a lot for Bartonella still. They have a panel that's like five IFAs, immunofluorescence,
Yes.
antibody testing, with like five Bartonella species. It's really helpful if you're trying to differentiate, and it's probably a little bit more sensitive. I mean, the immunoblot's pretty good with IGeneX too, but if I'm sort of honing in on Bartonella, I might run that. If I'm not, maybe running a fancy fish or T-Lab or something. But the fish itself on IGeneX is pretty inexpensive too. So it's not a bad idea to throw like $200 or something on some of these tests, just as you're screening if you're not sure if you're going to get much of a response from them. And that also tells you because RNA is more recent. It doesn't stick around like DNA. Like you could have like a mammoth that's 10,000 years old that has some DNA, although albeit somewhat
Yeah.
fragmented possibly. But an RNA does not last that long. It's just like a few months at the most, I
Right.
believe.
And to clarify for those that don't understand, PCR tests are DNA.
Yeah,
Fish
that's right.
tests are RNA, rRNA. And then, these immunoblot or antibody tests that we're talking about are really measuring the immune response. So those are indirect versus the
That's right.
PCR and fish tests that are direct tests. This is where T Lab kind of comes in, which
Hmm.
I have to say that it's of all the labs, it's probably the most expensive. It's the most out of reach for most of my patients,
Yeah.
right? I think per species, it's about $700 for the fish test for each species. And so you're
Yeah, it's
looking
like 700, 800. I think it might be even closer to 800 in some, I think.
it might be.
Yeah.
I haven't looked at the latest pricing guide. However, game changing in a
Yeah.
lot of my pediatric patients with immune compromise. So
Yeah.
if a patient's on IVIG, if they've been sick for a lot of years and they have tested negative to everything else, they've been to every other doctor, they have all the clinical symptoms of PANDAS PANS, and we're like really like needing information. These tests shine.
They
And
do.
and I mean shine. Like give me goosebumps, like we finally have answers. We
Yeah.
finally have treatment direction, you know. And frankly, it gets outside providers' attention, you know. We're like, argue that, you
Yeah,
know.
it's hard to argue like it's either there or it isn't. And that test is suggesting that it's either there or it isn't. And I've had plenty of negatives on those tests too. People will always be like,
And
you're paying for a positive, like there's been all that criticism of IGeneX too. Is it like is it ever negative? Like I've heard that before.
positive predictive value. We know the patient it likely has these infections, right?
Right.
So there we have a high, like I'm not sending somebody to T lab that I don't really think has these infections,
Right.
right? So you're right, I'm paying for a positive. Like, but at the same time, I have had negatives through T lab, and it's,
It's actually
unfortunately,
kind of reassuring sometimes when I get a negative. I feel good about that because I feel like I've trusted it enough to have
yeah,
that objectivity. And so like if their Bartonella is negative, I'm like, great. That's cool. I know I'm not saying it completely rules out like all Bartonella subspecies, but it's certainly nice to not see it sitting in the blood there. Because that's really
Right.
what that test is showing, is it's kind of showing this like, microscopic, staining of the blood cells, and it'll show RNA from these different creatures, and it's hard to deny
And
that it's there.
what I love, the other part that we haven't even mentioned about TLAB is that you actually get a visual picture
That's
of the
it.
slide of your patient's blood,
Hmm.
and you can see the positive Bartonella, the immunofluorescent tag
Yeah,
put already on there. There's nothing like a picture. I was gonna say, can I hold up my phone and show a picture? Will
you
it do
might be
that?
able to. You can give it a shot.
Is that lame?
Yeah.
I just want people to see like what you have the capability of being. I could have had this pulled up. Every time I have a teenager in here, I'm like, can you help me find this? I
Does
need
this thing work?
help. Okay, now this is, I always do say that these are dramatic pictures, right? Because, I mean, that's the reason why I'm using them as samples, but they're more dramatic in there. Okay, so can you see that? My lighting is really bad. I'm sorry, you're getting a glare, aren't you?
Yeah, but
I'm sorry. I don't know if
to
you
where
can
that would
kind of
be.
see some of this, but that yellow right there is the
Mhm.
immunofluorescent tag for Bartonella Hensley.
Right.
There's only a tag, to my knowledge, at this time for Bartonella Hensley, but I know that the medical director, Dr. Robert Mozigani for TLAB, is trying to come out with a genus species to where it will detect all the Bartonella species. But
Yeah.
like regular red blood cells should not have any of that Bartonella in them. And that Bartonella, we don't know if it's on or in the cell. I know that that has been something that we don't know. But you can see that this patient's blood, right?
Yeah.
Several of the cells are infected.
Yeah.
Anyway,
Yeah, it's
I
hard to
think,
deny that when you see it. I mean, it's like it shouldn't normally be there. And if the person's symptomatic otherwise, I mean, it's hard to argue that, and it's hard
right,
not to consider treating that. I mean, I think in one form or another. It doesn't mean you have to do antibiotics or whatever, but just like treating it in some form,
right.
or helping the immune system in some way. Like it just the picture is a picture does make it more profound, or make it more like
Tangible.
real. You know?
Yes, it's more real for sure. So part of that, you're paying for the technology of that, right?
Yeah,
And
that technology has been around for a while, but it hasn't come in this form until recently. I mean, I remember seeing those pictures like that, for iLads after iLads, just from like a research perspective. And it's they're always really beautiful. They show like biofilm structures and crazy stuff, like, and you're just like, whoa. I remember the first
whoa,
iLads I went to, I remember seeing those type of pictures, and I was like, okay, well, there it is. You can't argue that it exists. It's
there
like
it is.
there. And you could say,
And
well, maybe that research methodology is like that. If you're an academic, maybe you could try to argue that, but I'm trying to trying to
I
say,
would I feel like knowing the medical director for TLAB, he's crossed every T and dotted every I and making sure that this is as bulletproof for being able to pick apart the science
yeah,
and the legitimacy of the lab. He's gone through the highest level of laboratory certifications, right? So I appreciate that because I'm kind of a lab snob, as you are, right?
yeah,
Like I don't usually use like DNA connections. Like and
no.
And I'm not here to bash DNA connections. It probably has its purpose.
Well, yeah, like maybe in like
Just because it's a PCR.
have you have found, well, just as an aside, have you found value in doing some of those urine tests? We didn't talk about them, but for like say really young kids, you don't necessarily want to stick with the needle right away. Would you be, open to doing a urine test on like a 1 or 2 year old even, or something like that?
Oh, sure. Like the urine antigen tests. Yeah. I
Yeah.
would I would prefer the urine antigen tests over the PCR testing
Yeah,
if I
fair
was going to
enough.
do it. Yeah.
Yeah.
Yeah, yeah.
Yeah, but
But
urine has value in some ways for screening, in your
it
opinion.
sure does. But that's also if we can get the pathogen in the urine for
Fair.
action.
Yeah.
Right. So some of this is like again, it's hard. Testing's not easy, and it's often nuanced. And sometimes if I get a patient in here who is limited on funds, and I know that I'm going to want to retest them. Sometimes I'll do an empiric treatment for 2 or 3 months, see how they fare with treatment, see their response to it. And I do want to test. Like I think it's our duty to ask for testing, right? To some degree and say, look, we should have some positives. If we're using long-term antibiotics, we should know exactly what we're treating,
Yeah,
right? I
I think
mean,
that's
I feel
fair.
better with it. I feel better with it. Like, if not for them, for me.
Absolutely. No, I mean,
So,
I think we should try and do our due diligence in terms of like testing and getting some objectivity for sure. Because I
yeah.
mean, you could follow all the patterns, all the signs and symptoms, and all the what you normally see clinically and other things like that, and then the person's responding to treatment and all that kind of thing. But it's like, yeah, we should be diligent, and that's why I respect that folks are trying to get get better tests out there, doing the research and
Yeah.
everything, and even I didn't IGenics just get like an FDA approval on a test. I believe they may have.
Oh, I think you're right. I forget which test it was. What one was it?
It was some kind of I want to say it might have been one of the immunoblots. Don't quote me on that. Shoot, yeah, I was gonna look that up. But yeah, there was a because there was a question of whether some of these alternative tests that weren't exactly like integrated into the usual LabCorp quests and different things like that were gonna be able to survive long term without the approval. So some of these companies had been trying to do that because there was some sort of it was either a statement or something was released suggesting that there might be a crackdown or a consolidation of testing that may happen. And it's not like these tests aren't, they've been well researched and tested and they've gone through the usual vigorous, processes. It's not that
Right.
they haven't done that. It's just that like for one reason or another, they haven't been completely integrated into the conventional platform. And it's like it's not like they haven't tried. I'm pretty sure Igenix has tried, for example. So I don't
Right.
know. I can't really speculate to the reasoning outside of, possible politics and things of that nature that
That's
there's a there's a active and willful sort of denialism in this world, in this realm. And
There
even,
is.
the IDSA had sort of stated several years ago that they understand that their research and their guidelines are kind of old and need updated, and they don't really have great data supporting the current guidelines, but there was really no change that happened to said
Right.
guidelines, and that goes deep into the testing and the treatment elements and all these other things. And so it's like, well, why would the IDSA not be wanting to do what's best for the population? And it's like, I don't know. Ask them.
That's a question for their IDSA.
Yeah,
Right.
exactly. I can't explain it
So
either. All I know
it's
is
like,
that
yeah,
testing is a very integral part of the journey of Lyme, tick-borne infection, chronic illness, and everything. And that, if we can get some of that testing done early enough, there's much less question of like what we should do and how we should do it. It's in some ways way simpler. But the longer it goes on and the less we have access to early testing and early treatment, the more complicated it gets, and the less straightforward the answer is. It goes without saying.
I
So,
agree.
yeah,
Okay, I have another scenario for you. And I
please.
know I'm going overtime because we always do. We always say this is going to be 30 minutes, and here we are, not 30.
It's not 30
Okay.
minutes.
But I have a scenario for you. Patient is new to you. They've been through Lyme testing, they've been through Lyme treatment, then they were tested again and they were negative, right? And they come to you and they say, Dr. So and so, I came from him, and he cured my Lyme.
Weird.
Cured. He
Weird.
cured my Lyme. My testing was negative. He cured my Lyme.
Mm.
What do we say to that? I know what I say to that, but I
Oh my
can tell you
gosh.
it's not what I want to say to
The
that.
C word. I mean,
C word. Don't say the C word. I know it's bad. It's a bad word.
it's,
So,
it's a
but
hard
can
word.
I just tell you that that does so much, I don't want to say harm, but it does some damage
Yeah.
to that patient long term because they think that their Lyme has been cured, even though we know that there's an infectious soup in there, right?
Yeah.
And you can't parse out Lyme from the other infections. And knowing what we know about biofilm, it's not gone. It's not gone,
Yeah.
right? But do you use these tests? And I no knocking on you if you do. I don't happen to use these tests to find out if patients are negative or not, with the exception now of the fish tests, fish through IGeniX or fish through TLab, because
Yeah.
now I can actually see if the patient is genuinely negative.
Well, now I frame it as, is this active or not? Like, is this something that's active or,
Yes.
because I have to be very clear with people that sterilization of their system of an infection is not always possible. If you're able to, and it also, even if you catch something really early and you hit it with really hard antibiotics, there's always a possibility that something survives, or maybe it came in as a biofilm. Like maybe a biofilm was actually what was introduced. That is possible. We can't just think of biofilms, we talk about that later, as
Right.
something that's like a progressive process, because sometimes we actually get exposed to them. They're on surfaces or somewhere outside or within the tick, body or something like that.
Right.
So assuming sterilization, aka assuming
Cure.
cure, is not really the truth of it. It's more like marginalization if you want to go there. It's marginalizing the population down to some level that we can't exactly measure. And the hope is that your immune system is taking over on the other end and keeping it
Exactly.
under control and keeping it suppressed. So yeah, I mean, we have to really have that conversation with people, and I've folks out there that want have the hubris to claim cure and eradication and all these types of things. There are very few studies suggesting that eradication is possible. Although with tafenoquine and babesia, there was a study I think in like mice or something like that that had suggested that there could have been eradication of babesia from tafenoquine. So sometimes we get those exciting little snippets, and we're like, the possibility of annihilation. I can't. Oh my gosh, I'm so excited. But
However, like these things, like to say that you cured something is so short. Like I just think of all the nooks and crannies and biofilm communities in the body where you could have like a nest. And Jamie, I use the same vocabulary with my patients. I say, look, my whole goal is to get the pathogen load down to where your immune system is back up on top, right? Handling the load. Because really your immune system can and will handle the load on its own,
yeah,
right? If we take out all the thorns, right? And so,
most of the
yeah,
time, yeah, most of the time, unless certain circumstances. But yeah, you want to
I
get to
agree.
that point, and then that's why you might want to do immune therapies too. And so like there's complicated factors we don't need to get into here, but
I actually had a patient with low immune globulins. They were diagnosed with chronic variable immune deficiency, which is a pretty common. That's the most common immune deficiency that's diagnosed, CVID. And they were on long-term IVIG. Once they had appropriately treated their tick-borne diseases, I kind of mentioned ahead of time. I said, I really think that you likely don't have a long-standing CVID.
yeah.
I think that that might be resolvable, but I don't know yet. Time will tell. And sure enough, they were able to come off of IVIG. It
Yeah,
restored
it's
them.
common not because it's like genetic or it's some kind of mystery. It's common because there are a lot of chronic infections that potentiate it. And one of the most common ones that I see, of course, is Borrelia species, Borrelia burgdorferi especially. And you'll see that gradual decline. And then just like when you start treating, you'll see that gradual, sort of increase. And it may take sometimes years to recover it completely. It is theoretically possible to recover it, and I've seen it happen before. So it's helpful to see the CVID presentation to get the IG, because that's what insurance will sort of play
Right.
as. But under the surface, you have to remember that some of these things are actually caused by infections. Not as much mold and stuff. We'll talk about that later, but like mycotoxins do a different thing to the immune system than that. So
Exactly.
just keep that in mind out there. If you have low IgGs, there could be infection there, and somebody should probably fine tooth comb it and really try to figure out if it is treatable.
And it doesn't necessarily mean that you're immune deficient.
Yeah,
You might be immune consumed, which I use that term a lot with patients, where those IgGs might just be used up, right, in a complex, because we aren't measuring IgGs outside of a complex,
that's right.
right? So
Yeah.
we're bound in a complex. And if you have a lot of pathogens, you have a lot of complexes.
Yeah,
But
I mean, one way you can discern it is if they get like all these other infections all the time, like sinus infections and respiratory infections and everything under the sun, like that their kid brings home. Like there's certain circumstances where there's dual presentations. They look like a CVID immune deficiency, and they have, so. So
absolutely.
you do have to differentiate that and hopefully have, well, I don't know. In an ideal world, you'd have a good immunologist in there, but they're hard to find too. No offense, but
Okay, so let's say to like summarize, like tell me like what your top labs are and kind of like just as an overview, like
okay. Yeah,
what
so When it comes to antibody testing, my top two are Genix and Galaxy probably these days. When it comes to T cell or lymphocyte testing, like ELE spots, I interchange between Armin and Infecto labs. Depends on what I'm looking for because some of them have better things and others have better things. Depends on what I'm treating. And then for RNA testing, or direct testing, we should call it. It's IGeneX has the fish. They have the culture enhanced PCR. I don't use it as much. I use it a lot for a year. Sometimes it's helpful. And then I have the T Labs, which is the lovely visual RNA test. So that's kind of my top three types of testing and sort of the ones I use the most.
Right. Okay.
How about yourself? Is that about?
I'm pretty similar. I don't do PCR testing. So I don't do urine or blood PCR testing as a rule. I haven't found it that sensitive. It's decently expensive. And I'm like, I'm not getting positive. So I quit running it. And perhaps, I mean, when I listen to you talk about it, I'm like, well, maybe I should be running this more often. I haven't used Armin Labs. I haven't used Infecto Labs. I actually have just really liked IGeneX Galaxy and T Lab. And I might be missing something. And it's
Yeah.
totally true. But I just don't use the other labs. So
One area that was really interesting to look at PCRs. And by the way, I mean, the culture enhanced PCR is just sort of like a way that it's kind of like that Galaxy Lab one they did with Bartonella, where they sort of like grow things out in a certain medium and then sort of figure out. So you have one cell in the blood sample, so then you amplify that to 200 cells or something, and then the PCR will actually work. So it's like a PCR needs help. That's really the point. So
right.
in some cases, that's really the only ways that I've used them. But the other application we'll talk about with viruses someday, because it would be worthwhile having a whole discussion on viral elements in these cases, because I think they're really important and sometimes neglected. But there are, classic PCRs you can run through that test the number of viral copies of DNA in the blood. And it's kind of cool because, when those are really high, like there's definitely been a suggestion of replication. They don't just like stay high in most people. That's kind of an interesting thing. So there's certain circumstances there where PCRs could be cool, but for the most part, I agree with you. Yeah, they're kind of not the
Yeah.
best. I think the RNA is a
I am kind of walking back a little bit to say that I do actually use PCR for viruses.
yeah, fair enough.
Yes, right. So I'm like,
But we
you
weren't
are
talking
correct.
about viruses. Like I
I know.
said, we'll talk
Right,
about
right.
viruses some other
But
time.
for my tick-borne diseases, I just don't run them, you
Yeah.
know. And part of it, like even when I go through T-Lab, I try to get patients scholarship monies, to try to afford it. Like if they can't afford it, just because it's so expensive. And we have some really good scholarships that we've talked about previously.
Yeah.
Like,
Right
yeah.
on.
And so I try to get them scholarship to pay for it. And
Yeah.
and so far we've been pretty successful with that. Thank goodness.
Yeah. No, that's awesome. Yeah, like the Limelight Foundation, I went to their Dart for Art like, a couple weeks ago. That was really cool. Like
Oh, nice.
Brandon got
Oh,
some art and it was really fun. And yeah, it's a great event,
they're
by
my
the way.
favorite. They're my favorite organization,
Yeah.
and I just straight up put out there like, look, I think the patient has this, and they've tested negative to everything else. They're responding positively to treatment. I'm giving this clinical diagnosis, and we need T lab just to verify, right?
Yeah.
And and they'll usually award the scholarship for the testing for T lab.
What's the age limit on
I think it's
Limelight?
25.
25, that's right.
Yeah, yeah,
Yeah.
yeah. Which
So
I wish that there was an extension on the age limit.
I know I wish there were some like adult things. I have folks that are in their like 30s that they've been sick since they were kids. It's really
I
sad.
know. I
They
know.
don't
Can
have
we go
any
from one
additional
conflict?
resources, you know.
Yeah.
But
Yeah.
there's that sort of situation. But I mean, I think we'll hopefully be seeing more of that. And then there may be other opportunities out there, and I'm going to have to look into that. We will do a whole segment on that type of stuff
Yeah. Let's do a whole segment on
in the
that.
future for sure.
Okay.
Okay, well, I think this is pretty good for today because we went longer than we expected. I think our next
Flexible.
segment we'll probably talk about mold testing because I think that's always a fun one. Because the truth is there's nothing absolute in this world when it comes to mold either. So it's kind of nice little part two, so to speak, to this series.
Truth is what?
Oh, my
You're
internet
cutting out.
connection went bad. I
You
said,
cut out just a little bit.
let's see
Yeah.
if it comes back. Your internet connection is unstable. I would say the mold is a good follow-up to the Lyme because the Lyme and the mold are both have they share a lot of uncertainties in terms of testing, and if you ignore one for the other, you might run into trouble. So it's kind of important to understand where they coexist and where they become a problem with each other. It's like imagine you could test the general population, they might have Borrelia or something like that. But some of those people are symptomatic and some aren't. Imagine if those people who aren't symptomatic now step into a moldy environment, are they going to become symptomatic? They seem to be more likely to become symptomatic. So in some cases, you have to understand the presence of the infection alone isn't the whole story. So next time we'll talk a little more about toxins, especially
Toxins,
mycotoxins,
mold.
the
Yeah.
mold. Good times with mold. I have a lot of
Good
stories.
times with mold.
I'm sure you
Okay.
do too. All
Yes.
right. Well, thank you,
All right.
Janelle. Thank you,
Yes.
everybody, for listening.
Have a great night.
Have a good night, and we'll see you soon. We are confronting the complex, and everybody have a great evening. Bye-bye.
Good night.
Thank you for listening to our podcast, Confronting the Complex with Dr. Janell Payne and Dr. Jamie Kunkle. As a reminder, the views, thoughts, and opinions expressed by Dr. Jamie Kunkle are solely his own and do not reflect the views, policies, or positions of Gordon Medical Associates or its affiliates. Any content, discussions, or advice shared on this podcast are independent of Gordon Medical Associates and should not be interpreted as a representation of Gordon Medical Associates. Gordon Medical Associates does not endorse or take responsibility for any statements or viewpoints expressed in this podcast. Thank you, and I'll see you next time.